So I will do this talk together with an excellent pathologist from Rome, Franco Zannoni, who works with Antonia Testa. And I wish that I had the possibility to work with such a passionate pathologist. You know, as ultrasound examiners, we base our diagnosis on the macroscopic appearance of the tumor because the ultrasound image gives us a macroscopic view of the tumor. And some tumors have such typical macroscopic appearance that we as ultrasound examiners can dare to suggest a diagnosis on the basis of the ultrasound image that reflects the macroscopic appearance of the tumor. Yes? Closer. Oh, okay. Where was I? So, and of course, also the pathologist uses the macroscopic appearance of the tumor and the clinical information of the patient to arrive at the correct diagnosis, even if the pathologist also, to make the final diagnosis, of course, uses microscopy. As ultrasound examiners, we can also look at the vascularization of the tumor using Doppler. The pathologist can see the color of the tumor and can use the smell of the tumor to make a diagnosis. And obviously, as ultrasound examiners, we cannot use that information. So what we are going to do together is to describe to you the typical clinical presentation, macroscopic appearance, and ultrasound appearance of some rare tumors. And we have chosen two sex-cord stromal tumors, the granulosa cell tumor and the fibroma, and two germ cell tumors, the dysgerminoma and the immature teratoma. So let's start with granulosa cell tumor, and I give the word to Franco Zannoni.
We are starting with granulosa cell tumors, in particular adult granulosa cell tumors that belongs to sex-cord stromal tumors together with fibroma tecoma, Sertoli stromal tumors, sex-cord tumors with annular tubules, gynandroblastoma, and unclassified sex-cord stromal tumor. Adult granulosa cell tumors represents 1% of all ovarian tumors. And when we consider granulosa cell tumor, 95% of them are adult type. The tumor is typically unilateral, and its average diameter is 10 centimeters. The tumor is frequent in reproductive and postmenopausal ages. Adult granulosa cell tumor is typically estrogenic, and sometimes you can find associated endometrial hyperplasia, and 5% of them low-grade endometrioid endometrial carcinoma. Rarely the tumor is androgenic, and when is it? When it is cystic. When the tumor granulosa is cystic, is androgenic. We can find this tumor in hemoperitoneum in 10% of cases, and this means tumor rupture. The most of the tumor presented in stage 1 at the diagnosis, and I remember you that the stage is the most important prognostic factor. The tumors tend to recur late, and for this reason, a long follow-up is mandatory. The prognosis of this tumor is quite good because recurrence rate for stage 1A is from 10 to 15%, and overall 20–30%. Extravariant spread is generally in peritoneum and omentum. Can we predict granulosa cell tumors that have a bad prognosis? Basically, no. But we have some unfavorable factors, such as advanced stage at the time of the diagnosis, large size, more than 15 centimeters, when the tumor is rarely bilateral, and if there is tumor rupture. This is an example of macroscopical aspect of granulosa adult type. You can recognize a solid pattern with multiple cystic, like a Swiss cheese, as you can see in ultrasound, an area of hemorrhagic and necrotic area. But necrotic and hemorrhagic appearance may mislead initial interpretation, especially in frozen section. So it can be a difficult diagnosis for us. Histologically, we can recognize the typical pattern of a microcystic appearance that we call a Kohl-Exner body. And this is an example of cystic granulosa tumors that is invariable androgenic. It's very difficult to recognize the tumors because it's composed of a small layer of cells. And this is our pattern recognizing, Tom. You can recognize small cells, and it reminds coffee bean because the cells are grooves inside the nucleus.
Okay, so now I will tell you about the typical ultrasound appearance of granulosa cell tumors. In an international multi-center study, we collected clinical and ultrasound information on 23 granulosa cell tumors that were examined with ultrasound before surgery. And using pattern recognition, we were able to recognize two typical patterns. The first one is the so-called Swiss cheese appearance, a multilocular solid tumor with quite a lot of solid tissue surrounding cysts of varying size. And when we see this ultrasound image, I think we can imagine what this tumor looked like on microscopy in real life. The second pattern was the one to the right. It's a solid tumor with smooth borders, but with very heterogeneous internal echogenicity. And when we see this ultrasound image, I think we can imagine what this granulosa cell tumor looked like in real life. And in our series, most granulosa cell tumors were moderately or highly vascularized. This is an example of another solid granulosa cell tumor. It has smooth borders, but very heterogeneous internal echogenicity, and it is moderately vascularized on Doppler ultrasound. This is an atypical ultrasound image of a granulosa cell tumor because it is purely cystic. It is very rare for a granulosa cell tumor to be purely cystic, and it is extremely rare for a granulosa cell tumor to be a unilocular cyst. Now, outside the series that we collected in our international multicenter study, we have recently diagnosed 2 granulosa cell tumors in my institution, and these are the ultrasound images. This is an 11 centimeter multilocular solid tumor manifesting the Swiss cheese appearance in part of the lesion and moderately vascularized on Doppler ultrasound. The presenting symptom was postmenopausal bleeding because the granulosa cell tumor secretes estrogen. And this is the second case, a very small solid tumor with smooth borders but heterogeneous internal echogenicity, extremely richly vascularized on ultrasound, and the presenting symptom was again postmenopausal bleeding in a 51-year-old woman. So now we move to the next sex cord stromal tumor, ovarian fibroma.
Yes, moving on ovarian fibroma that arise from specialized ovarian stromal cells. It is the most common stromal tumor, and 4% of all ovarian tumors are fibroma. We have to keep in mind that there are 2 variants important for clinical consideration and in particular for histological consideration, that are cellular and mitotically active fibromas that represent less than 10% of all fibromas, but explain most diagnostic problems. Fibroma is most common in middle-aged women, and it is typically unilateral. Occasionally, it is bilateral. In particular, it is bilateral in a Gorlin syndrome. So if you look at a bilateral fibroma bilateral fibroma with microcalcification, think about the possibility of a Gorlin syndrome. Abdominal pain is the most common symptoms, and sometimes we can have increase of CR 125, and it's a big problem when increased CR 125 is associated with ascites and makes syndrome, that is ascites plus pleural effusion, because we have a suspicion of cancer. In this case, if I understood well, simple rule don't work. Solid, great. And I remember the association with Gorlin syndrome. This is a typical macroscopical aspect of fibroma. It's a lobulated tumor, solid, follows the surface of the tumors, it's irregular. And in this case, it's very interesting because the tumor is white and yellow. White means fibroma, generally. Yellow means function. Probably this is a tumor that doesn't function here, but probably produce estrogen. From the histological point of view, the tumor is composed of small cells, and we can recognize this deposition of collagen, hyaline plaque. We have three variants that we can recognize: cellular, approximately 10%, mitotically active fibroma, and fibroma with sex cord-like elements, clinically irrelevant, the last one. The most important are cellular fibroma and mitotically active fibroma, because 10 years ago, they were called fibrosarcoma, and it's very different from the prognosis that is benign in both cases. Cellular fibroma is a tumor with cellularity similar to that seen in a diffuse adult granulosa cell tumor, while mitotically active fibroma is a fibroma with absent or mild atypia, but wide range of mitotic activity until 15 mitosis per 10 HPF. From the macroscopical point of view, cellular mitotically active fibroma and cellular fibroma present larger and softer in comparison with conventional fibroma. But the most important clue is the tumors can be less mobile because create surface adhesions around the tissue in ovary. But the prognosis is good for all the type of fibromas. We can consider that some cellular fibroma can relapse, probably because they are not removed completely. Someone called this kind of tumor fibrotecoma, but fibrotecoma really does exist. For many pathology, fibrotecoma doesn't exist because it's a mix for a fibroma and tecoma. But in most of the cases, pathologist is able to recognize if the tumor is a fibroma or tecoma. From the clinical point of view, we have to consider this kind of tumor like a fibroma, where there is probably a luteinized or tecoma component.
So I will now describe the typical ultrasound features of fibromas and fibrotecomas. In an international multi-center study, we collected clinical information and ultrasound information on 55 women with a fibroma and 15 women with a fibrotecoma that had been examined with ultrasound before surgery. And using pattern recognition, we were able to describe 5 features. The most common ultrasound feature was this one. We have a solid, round oval or lobulated tumor casting stripy shadows. The internal echogenicity could be homogeneous or heterogeneous. There could be cystic spaces, or there could be no cystic spaces. Is it this one? This one. So this is the most typical feature. You have a solid tumor casting stripy shadows with regular internal echogenicity. Here you have also a solid tumor casting stripy shadows, but there are also small cystic spaces inside. And here we have an oval, a solid tumor with smooth borders, some cystic spaces, but very faint stripy shadows. This pattern was present in 66% of the fibromas and fibroblastomas in our series. The second most common pattern was this one. We have a solid, round oval or lobulated tumor, but without stripy shadows, and in most cases, the internal echogenicity was quite inhomogeneous. And in some, there were cysts, and in others, there were no cystic spaces. 23% of the fibromas, fibroblastomas in our series belonged to this category. Then 5% of the fibromas and fibroblastomas in our series were also solid, round, oval or lobulated tumors, but the echogenicity was so dense that it was not possible to characterize the echogenicity of the solid tissue. And then in another 5%, the fibroma manifested a multilocular solid appearance with heterogeneous echogenicity and many cyst locules and no stripy shadows. And you see two examples here, and I must admit, I would never have suggested a diagnosis of fibroma seeing this image. It would rather have reminded me of a granulosa cell tumor, but it was a fibroma. And also in this case, I would never have suggested a diagnosis of fibroma in this multilocular solid tumor. And then there was actually also one mainly cystic fibroma in our series. And most fibromas and fibroblastomas in our series were poorly vascularized or moderately vascularized, even if there were also a few fibromas that were very richly vascularized. So now we move to a rare tumor, dysgerminoma.
Dysgerminoma is the most common malignant germ cell tumors, and it represents from 1 to 2% of all ovarian tumors. 18% of them are monolateral, unilateral, but 10% are grossly bilateral, and an additional 10% are microscopic bilateral. There are generally large tumors, more than 10 centimeters in diameter, solid. We can find foci of hemorrhage, necrosis, or cystic degeneration. And it's very rare, under 5 years and over 50 years. May occur in gonadal dysgenesis, usually from a gonadoblastoma. Biomarkers can help you in LDH elevated, and in rare cases, HEG. Rarely, we can find hypercalcemia. Symptoms are related to abdominal mass. The good news is that the prognosis is good. 5-year survival rate is almost 100% for stage 1 tumors, and very high for higher stages or recurrent tumors. This is the typical aspect of dysgerminoma. You can follow the border of the tumor is lobulated, irregular surface. And the cut surface of the tumors show multiple lobules. Histologically, they are composed of primary germ cells surrounded by fibrous tissue infiltrated by lymphocytes.
So now I will show you the typical ultrasound images of dysgerminomas. In an international multicenter study, we collected clinical and ultrasound information on 21 dysgerminomas that had been examined with ultrasound before surgery. And our results confirmed those in textbooks of pathology. These tumors were generally very large. The average diameter was 11 centimeters. They were solid, and the most typical ultrasound feature was the presence of lobules. I will show you in a moment. And usually the echogenicity of the solid tissue was heterogeneous, and they were moderately or most frequently extremely abundantly vascularized. So you see here a solid or 3 solid tumors. They all have this lobulated surface, but most typically you can also see that there are lobules inside the solid tumor. And here is another example, lobulated surface and lobules inside the tumor. And this is a very typical example. It's a huge tumor, and you see the lobules inside the tumor. And there is also a slightly lobulated contour of the tumor. And another example, again, a huge solid tumor, and you see the typical lobules of the tumor, and very richly vascularized on ultrasound. And this is a 3-dimensional image of the vascular tree of a richly vascularized dysgraminoma. Okay, so we move to the last type of rare tumor, immature teratoma.
And finally, immature teratoma. It's the second most common malignant ovarian cell tumors, most frequently before 30 years of age. It's typically unilateral. You can find a teratoma in a contralateral side, but always mature, because immature teratoma is basically unilateral. It's a large tumor, and we can have increased alpha fetoprotein. This is the typical aspect of ovarian immature teratoma. You can recognize solid patterns with different tissue inside, vesicles, solid, cystic, hemorrhagic, necrotic. From the histological point of view, is a combination of cartilage, glands of respiratory type, and nervous tissue. But the most important features we look for is neuroepithelium, immature neuroepithelium. And by the presence of the amount of the immature neural tissue, we can give a grade of the tumors. And we divide the tumors in 3 grades, depending on the amount of immature neuroepithelial tissue that I showed before. So it is most important for the pathologist have the tumors and take a lot of blocks to identify the amount of the presence of immature neuroepithelial tissue, because depend the treatment for the patients.
So now it's time to look at the ultrasound images of immature teratomas, which are extremely rare tumors. So for the purpose of this lecture, I contacted my ultrasound friends and asked them to send me clinical information and ultrasound images of immature teratomas. And I received information on 10 cases of primary immature teratoma. Luca Savelli also sent me information on recurrent immature teratoma, but I chose now only to show cases of primary immature teratoma. The results partly confirmed what is said in textbooks of pathology. The women were young, but surprisingly many were 30 years or older, and the oldest woman was actually 50 years old. So only 4 out of the 10 patients were really young, younger than 20 years. All the immature teratomas were large, between 12 and 28 centimeters in diameter. All were unilateral. So this confirms what textbooks in pathology say. According to textbooks of pathology, these tumors are usually solid, but in our series, actually 8 out of 10 were mainly cystic, and only 2 were mainly solid. And the most typical feature is the very heterogeneous echogenicity of the solid components. And none of these 10 immature teratomas was well vascularized. So 2 of the immature teratomas in our series were mainly cystic, but with a solid component that seemed to arise from the cyst wall like a huge papillary projection. And you can see that the echogenicity is very specific. It's very heterogeneous. But the solid tissue was not very well vascularized. 3 immature teratomas were cystic, but with a larger solid component than in the previous 2 cases, and these solid components, they also seem to arise from the cyst wall, and you can see the very heterogeneous echogenicity of the solid component. But these solid components were not very well vascularized on Doppler ultrasound. And then we had 2 huge cystic immature teratomas with a solid component, but not arising from the cyst wall, but with this very heterogeneous echogenicity. I think you can really guess what they looked like in real life with this rather disgusting mixed appearance. And the solid components were not very well vascularized. And then there were 2 tumors that actually were mainly solid, and with this very heterogeneous echogenicity, and not very well vascularized on Doppler ultrasound. And then there was 1 case which looked very different from all the other cases, because it was a multilocular solid tumor with a large solid component, and the echogenicity of the solid component is very similar to the echogenicity of the solid components of all the other tumors, very, very heterogeneous, but not very well vascularized on Doppler ultrasound. So I will conclude now our common lecture by saying that granulosa cell tumors of the adult type, they occur both in women of reproductive age and in postmenopausal women. They are usually large when diagnosed, but you have seen they can also be small, and they are usually unilateral. The most typical ultrasound feature is the Swiss cheese appearance, and another typical feature is that of a solid tumor with smooth borders but irregular internal echogenicity. It is rare for a granulosa cell tumor to be completely cystic, and they are usually moderately or abundantly vascularized. Fibromas and fibrotecomas usually are diagnosed in middle-aged women. They are usually large when they are diagnosed, but they can also be small. They are usually unilateral. The most typical ultrasound pattern is that of a solid, round, or oval or lobulated tumor casting stripy shadows. And the second most common is solid, round, oval lobulated tumor with no stripy shadows. Sometimes there are cystic spaces inside. Rarely fibromas are actually multilocular solid or completely cystic tumors. Dyscarcinomas occur in young women. They are usually large when they are diagnosed, and they are very often unilateral, 80%. On ultrasound, they are seen as large, solid, encapsulated tumors with heterogeneous echogenicity, but the most typical feature is the presence of lobules. And they are usually moderately or very abundantly vascularized tumors. And finally, the immature teratoma is a malignant tumor that occurs in young women. Most of them are 30 years or younger. And they are usually very large when they are diagnosed. They are virtually always unilateral. And on ultrasound, according to textbooks of pathology, they should be solid. In our series, 8 out of 10 were actually mainly cystic, but with large solid components with very heterogeneous echogenicity. And they were not very well vascularized. Thank you very much.
Thank you, Lil and Franco. I do love these lectures where you have pathology or you have other types of, dual interest involved in them. I think it makes a real difference to everyone's understanding. So, thank you for that. I mean, the one thing, one gets asked sometimes, when you see a dermoid, the difference between classic dermoid cysts or mature teratomas, and I suppose occasionally kind of people asked, oh, well, how can you tell the difference between those and immature teratomas? But looking at your images, they look very different. There was just one case, I think, I saw which kind of looked a little bit like it might look like a typical dermoid out of all the ones you showed. I think it was about the 6th one. Otherwise, they have very, very different features, don't they, which is quite reassuring, really. Would you agree with that?
Yes. So Tom is saying that he was worried.
Can you hear? Can you use those ones?
Okay. I think this is also definitely a question for the pathologist. So Tom was saying he was worried that we would not be able to discriminate a mature teratoma from an immature teratoma, but we showed you that the ultrasound images are really different from what we call a mature teratoma. I think the problem is when you have malignization in a mature teratoma, because that is different from immature teratoma, and it seems that we as ultrasound examiners, we cannot be expected to detect malignant changes in a mature teratoma, unless, of course, there are very large components of, for example, squamous cancer. Maybe you want to comment.
Fortunately, they are rare cases, but sometimes mature teratoma can contain a somatic malignant tumor, such as a squamous, endometrioid, melanoma. We say melanoma. We described also oligodendroglioma or glioblastoma arising in ovarian mature teratoma. But the treatment is quite different because the tumor is considered as somatic carcinoma, and the prognosis is not so well as for immature teratoma. So immature teratoma means a teratoma with neuroepithelium that I showed you. Somatic carcinoma arising in ovarian teratoma is another tumor. And is cured by like a somatic carcinoma, not like an ovarian carcinoma.